So I'm here today interviewing Dr. Daniel Heng, who I would describe as actually being a rock star in the world of kidney cancer. Dr. Heng is very modest, but he actually has a set of criteria named after him that we commonly apply in the clinic to ascribe risk to patients with advanced or metastatic kidney cancer. And Dr. Heng, first of all, thank you for joining us today.
Well, thanks for having me, Monty. That's great.
Absolutely. And I might actually start my questions out with one related to your system. Can you tell us how we apply Heng criteria in the clinic on a day-to-day basis?
Sure. So, as you know, the IMDC criteria are composed of 6 factors. There are 2 clinical factors, a cardiomyopathy performance status of less than 80%, a diagnosis, a treatment interval of less than 1 year, and 4 lab values. So hypercalcemia, an elevated neutrophil count, an elevated platelet count, and anemia. And so if you have 0 of those risk factors, you're favorable risk with a median overall survival of 44 months. If you have 1 or 2 of those factors, you're intermediate risk with a median overall survival of 27 months. And if you're poor risk, 3 or more factors, then you have a median overall survival of 8.8 months. Of course, these are all doubled since the introduction of targeted therapy compared to the immunotherapy era. How do we use this in the clinic? We use it for prognostication. Our patients always want to know, want to be able to plan their lives. Do they have 5 years left? Do they have 1 year left? And so it gives them some sort of benchmark. Obviously, they're just averages, and we have to be careful to not just quote a number. We have to be careful to say it's just a median. Many people do much better. Many people do much worse. And it really depends on how people tolerate and respond to targeted therapy. We can also use it in the clinic in terms of choosing patients for different types of therapy. So for example, poor risk disease patients are eligible to use temsirolimus, but they can also use other TKIs as well, like sunitinib or pazopanib. And also, more recently, we've used our criteria to try to determine whether or not a patient is a good candidate for cytoreductive nephrectomy. And so a cytoreductive nephrectomy, just to be clear, is in the setting of metastatic disease with the primary still intact, should we take out the kidney tumor in the face of metastatic disease? And so we found that by doing the cytoreductive nephrectomy, there was an overall survival benefit, but we also wanted to do a little bit more than that and see if there were any patient selection factors. So we found that if you had 4 or more of these factors, perhaps your prognosis isn't good enough to be able to do a cytoreductive nephrectomy. Maybe we're wasting your time if we do a cytoreductive nephrectomy, and we should get on targeted therapy right away, as opposed to making you go through surgery and then having to heal from the surgery just because your prognosis is a bit shorter. Obviously, there are exceptions to that rule. So for someone with very symptomatic primaries, they should probably be operated on or dealt with. But it at least gives urologists and medical oncologists a guide as to who might benefit from a cytoreductive nephrectomy more than others.
Excellent. That was a great synopsis. And let me ask you, looking 5 or 10 years ahead, this is somewhat of a provocative question. Mm-hmm. We have new agents potentially moving onto the scene. We've talked in some of our previous interviews about nivolumab, a PD-1 inhibitor, about cabozantinib, another VEGF and c-MET inhibitor. Mm-hmm. Curious to know whether or not you think the Heng criteria might potentially evolve over the years to incorporate different factors as all of these new agents come about?
Yeah, absolutely. And we're always trying to look for new things to add to our criteria to make it more applicable, more accurate. I suspect what's going to happen is these prognostic factors are usually independent of treatment. They usually don't change based on treatment. But what will change, though, is the associated overall survival. So, if we add more therapies that are more effective, instead of seeing 44 months for a median overall survival for the favorable group, maybe it'll be a lot longer. And so we'll try to update those as we go along when these trials report out.